Our formal brewing came from Cheng from UCLA, and now is a faculty at the UNC Department of Molecular Biomedical Science and and Biomedical Engineering. He's really also a newcomer in the stem cell biology, especially in engineering and cell therapy. Today, he's going to talk about bioengineering approaches for enhancing stem cell therapies. Please.
Thank you, E.B. It's almost impossible to speak after energetic and excited Ying. I will try my best. And first of all, thank you, Jay and Joe and GQ for the invitation. And I'm going to switch gear right now from the basic we have heard the two basic biology and chemistry talks, and we'll switch to bioengineering approach for enhancing the stem cell therapy. So after almost 2 decades of efforts in cardiac cell therapy through multiple meta-analysis, we know that cardiac cell therapy is safe, but with only marginal efficacy. So part of, as an engineer, trained as biomedical engineer, I want to think, and a pharmacoengineer as well, I want to think how that happened. So we always think that there's a view that we call adult stem cells are live drugs. And I think probably in the last decade or so, we're focusing so much on the live part, the first part, which we think you only need a very small amount of cells in the heart, and they can proliferate, and they will differentiate, and they will naturally home to the MI, and one dose is enough. But after some research, we now know that this is almost like magic, right? And actually, none of these things happens to. Now, I'm talking about the adult stem cells. I do believe that for pluripotent cells, these cells will form a large engraft, and they will proliferate and differentiate in the heart. So I'm talking about adult stem cell therapy, which is including MSCs and cardiac ones. We know that they have very limited proliferation and differentiation after injection. So we're probably going to focus more on the second half, when we call them with the drug part, which as a drug, as we know, during the development, you have to deal with a dose regimen and PK/PD, which stands for pharmacokinetics and pharmacodynamics and bioavailability, biodistribution, and delivery and targeting. So now let's look at these numbers. These are the embarrassing and poor numbers of cell engraftment after injection, regardless what type of stem cells and what type of delivery method. These numbers are single digit. And this actually comes to the question that if you deliver 100 cells today and 1 hour later there's only 10 cells left, how do you imagine this cell will work? And actually, this 1 hour quick loss of these cells, like to 5%, cannot be explained by cell death. So basically, there's a strong wash-away effect that once you inject the cells to the heart, because of the dynamic nature of the heart and the venous drainage, actually cells are actually lost to the lungs and to the livers. And actually, we heard a fabulous talk this morning from Dr. Bowley about the paradigm shifting, that it's a number game, that if you give multiple dosage to the patient or to the animal, actually you will have amplified effects. So in this talk, we're focusing on engraftment, but with I think these are the barriers to the cell therapy right now: low engraftment and tumorigenicity and immunogenicity if you're using allogenic cells, and also off-target effects. So I'm going to just show 3 brief cases that has been developed in the lab to tackle on these barriers. And actually, this summarized figures from one of our recent review paper. So the first case is deliver these cells into using a hydrogel that is thermal responsive hydrogel, which means they are a liquid format at room temperature, and after injecting, in situ polymerization will happen and form a stable gel. So the idea here, I think, repeated dose is important, but sometimes due to the invasive nature, if it's intramyocardial injection, it's probably be difficult to do multiple, and has to be IV or more or less invasive route. So I think our rationale is that maybe you can still do 1 dose, but prolong the cell persistence and actually against the wash-away effects. So this is showing some of the chemistry of this gel and as you can see here, the 37 degree, at room temperature they are liquid, and at 37 degree they form a stable gel, and this is showing an SEM picture. So we did the rodent study, but I'm actually only going to show the pig study, that in a This is a pig acute MI model that we inject the cardiac stem cells either in liquid, in PBS, or in this polymer nanogel, and actually we see that we'll be able to dramatically increase the retention of these cells, which is labeled with Texas red fluorophore. And as we now learning that these cells, the mechanism of action of these cells is not by differentiation as these adult stem cells. It's probably mainly from paracrine effects, which is pro-angiogenic and pro-cardiogenic mechanism. So we see that these delivered cells, they engraft, and also they recruit these vessels that go around them. So certainly this is not a protection, because you wouldn't see two parallelly lined vessels naturally. Actually, these are the vessels newly formed because of this the engraft of these nanogel encapsulated stem cells. And then we do see that with this engraftment, we translate it into a better functional outcome, that if you deliver the cells in the nanogel, you outperform the cells' controlled delivery method. So here, I think I want to show is that you encapsulate the cells, and they will release the beneficial factors, but then the encapsulation will help them against the shear force of the heart and also maybe the immune cell attack. So I would switch gear here to talking about the second case, which is about the targeted delivery, because as we know, the previous case still need open chest surgery, most likely inject to the heart, and the safe way to deliver the cells would be through the vasculature, as we know, like intracoronary and intravenous. And people may argue that intracoronary injection, everything is already go to the heart. Why do you have bother this targeting? But actually, if we see these numbers highlighted with yellow, these are all intracoronary injection. If you look at these numbers, it's mostly below 5%. So there's a lot of rooms to go, and 5% actually is 1 hour. So basically, you inject the cells to the vessel. They don't have a chance even to stick it to the vascular bed. Actually, they get washed away after the injection. So some of our early work is actually focusing on using a physical method, actually label the cells with RNA nanoparticle, and then using using a magnetic field to keep the cells longer. So these are the published work summarized in a review paper that with magnetic targeting, we're able to increase the cell retention in the heart and decrease off-target migration to the lung. So this is okay, but this physical method has a problem that it's very hard to articulate the magnet without the invasive to put it on the patient. It's very hard to precisely control that. So we developed the molecular ways, which is using bispecific antibody, has been a mature idea in cancer therapy, that one end is using antibody to grab the biomarker of the heart injury, such as MLC, and another end is to grab the stem cell antigen, and using this method to direct the cells to the infarct. Now the problem is that it's not very easy to get this antibody made, and if you purchase the antibody from commercial sources, is actually every time I see the high bills from ABChem and R&D, students may find some different method. So what I want to talk today here really is focus on, I then ask the students, can we find an agent that in our body that has innate ability to find injury? Maybe we can find a cheaper and effective way to target the stem cells. So actually there's something we know, that the platelet, after injury, the platelet will be actually recruited to the injured vasculature, and actually there's a published paper, and it's a clinical trial actually published, that demonstrated that after MI, actually the platelet will form co-aggregates with CD34 circulating endothelial progenitor cells. And actually there's a nice correlation between these co-aggregates with the prognosis of the patient. So basically, a patient who has more of these co-aggregates will have a better outcome. But how about this poor patient doesn't have this much co-aggregates? Because certainly this mechanism is that the platelet is a piggyback with the endothelial progenitor cell and help them to migrate to the infarct. So initially we think that maybe we can get the platelets and live platelets and then form a co-aggregate with stem cells in vitro and then deliver them. But then after the second thought, we think this is not valid, because live platelets is something we want to avoid in MI, because these are the culprits actually for acute coronary syndrome. So a talented student in my lab actually come up with this engineered way, which is we develop these nanovesicle from platelets. So this, you can call them the ghost platelets, which is they actually preserved all the coat of the platelet, has all this binding motif, but it's lack the intracellular machinery has been lacking, so they have no ability to cause the coagulation cascade. And then we fuse this platelet nanovesicle to a cardiac stem cell to make a hybrid, that a cell that has the payload of the stem cell secretion, paracrine factor still preserved, but with this binding motif. This is like adding little GPS to these stem cells from the platelet membrane. And actually we find that this, after the hybrid, after the fusion process, we see that this PMVCSC stands for platelet nanovesicle decorated stem cell actually express these platelet motifs that which were normally not expressed in the naive stem cells. And then we started using a rat model of ischemia reperfusion. We inject the cells. Obviously, you cannot do intracoronary in rats. What we do is inject to the LV cavity with the temporal occlusion of the aorta. So you create close the circuit, so to mimic intracoronary delivery. And actually, we see by imaging and PCR and histology, we see that we bump the cell retention. And this is confirmed using in a pig model, that we confirmed that this is real intracoronary delivery using the same strategy, and we actually confirm. I'm sorry for this busy slide, but just focusing on this here, we'll be able to increase acute retention of these stem cells after intracoronary delivery. So as we hear many talks in this morning from Krishna and Yao Liang and Michael, that exosome therapy really is the next generation. I think exosome therapy may benefit more from targeted delivery, because unlike stem cells, they cannot migrate, they cannot proliferate, and but they have they hold a huge potential for repeated dosing, because these things can be intravenously injected. So a student in my lab actually is working on using a cardiac homing peptide, which is these peptides will actually binds to cardiac injury, and we're using this peptide to decorate the exosome. And we actually some preliminary data here that we show that using this, it doesn't show very well in this projection, but actually can increase the retention. So the last story I'm actually talking about is something about synthetic stem cells, which is a recent work, a relatively recent work, which is we utilize the secretome of the cells. We take the conditioning media from the cell and pack it into a biodegradable PLGA particle to making a particle that it can control release, sustain the release of the beneficial factors from the stem cells. And we did the second stage is to encase this particle with a membrane. One may ask, why do you bother to put a membrane? I mean, since you already have the paracrine factor. Well, the result is that actually we know that from the literature that if you co-culture the cells, stem cells with cardiomyocytes, the effect is larger than putting conditioning media as a supernatant. So there's something to do with insoluble factors, which is a membrane of the stem cells is also very important. And actually, we know that from this cover, and actually if you enlarge it, you will see that the two cardiomyocytes actually sending their projection try to get, it seems like they get fed an interaction with this synthetic particle, which is coated with a cell membrane. And we don't see that phenomenon in an uncoated particle. And then we did a mice study, and actually we inject real MSCs and synthetic MSCs, and we actually see in these measures, the synthetic MSCs are just perform as good as real MSCs in this particular model, but they're more superior to the real cells, because now we are having a powder that you can even lyophilize this synthetic particle into a solid form, which is more stable in storage, even at room temperature, which can never be done in real live cells. And now we are also investigating whether the stem cells or these particles can get out from the vasculature using a zebrafish, transgenic zebrafish with these microvessels. And actually, I'm going to just show this image here, that we'll be able to take a journey through the vessel using light sheet microscopy to see the relative position of the stem cells to the vasculature, and do some fine-tuning how they actually come out from the vessel. So, and there's one last thing that I want to speak is that we are now also working on with unpublished data here, that working on with a cardiac patch with totally no cells, but with a natural ECM from the decellulated heart but actually embedded with these synthetic stem cells that we developed, as I mentioned before, with the hope that this bandage will, after put on the heart, will release the factors and promote regeneration. So with all of that, I think that really we're migrating from the first generation therapy using mostly bone marrow cells to where are we right now, using more organ-specific cells and ESCs, and then maybe the next generation is using the exosomes factors and cardiac patches. And this is showing this actually nice review paper that Dr. Brandon Ogle and we co-authored here, that maybe one day we'll be able to titrating the cells matrix and the factors and be able to making organs even in situ or in vitro. So with all of that, I would thank you, thanks the students and also the funding agency.
I will set up the next talk. Thank you.